Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm Hospice Nurse Penny.
And I'm Halley, Hospice Social Worker. Welcome back, Penny. It's season 2.
Oh my gosh, welcome back. Season 2 already. This isn't like TV seasons where you get one year and then you get a whole year off and then you got to come back. We're like
House of the Dragon where they make you wait 2 years.
Oh, that's true. Yes. Yeah. Maybe we should do that. Instead of waiting 2 months.
Yeah, I don't know about all that. But today we have a great guest for the listeners. We have Cody Hufstedler. He is a palliative care chaplain in a hospital and also the host of the Dying to Tell You podcast. And we will be talking to him shortly. But first, we want to give you our education piece.
Yes. Let's get to it.
Yes, we're going to talk about patient stories and HIPAA. I've talked a little bit about this before. Penny is much better at this than I am as far as telling patient stories. I am the absolute worst. You just don't hear me telling patient stories. And I realize my partner said to me after season 1, well, I heard you talking about the medical aid in dying episode and you said you were going to tell patient stories and then you didn't say anything. You just said how it generally was. Absolutely right. I meant to tell a little bit more of a detailed story on that, and I'm happy to add one in. But the point is that I really have a hard time. I'm so very careful. I lean so far on the far side of not making sure I don't tell anything wrong that I don't come up with good things. But you, I think, Penny, can explain better how you're able to do that.
Well, for one thing, I've worked at several different hospice agencies. So any patient story that I tell could be from any agency that I worked for. So right off the bat, people, aren't necessarily going to know who I was talking about because they don't know where I was working at the time that the story took place. Many of my stories are really old. I've been a hospice nurse for 20 years, so they're old. But sometimes it's just a matter of changing little details, their name, their gender, their disease, unless it's something that's like relevant to the story because of whatever symptoms are associated with that disease. So that's kind of how I do it. And one of the things we were talking about earlier is that death is a matter of public record. So when somebody dies, that information is public record. So anything about them that's been made public is fair game. If it's something personal about them that not everybody is going to know, like for example, if somebody was pregnant when they died and that had not been announced yet, that would be a breach of their privacy. One of the things I've seen lately that I find very troublesome is people on social media who work in healthcare, especially particularly home healthcare, who are putting videos of their patients on social media.
What?
Yeah. So I saw one recently where it was a home health caregiver. I don't know if she's private hire, if she works for an agency. I don't know in what capacity she's working or employed, but she is a caregiver. And her patient who she cares for has dementia. Not terribly advanced. She's still able to take her patient out, which is what she was doing. She had her in the car. They were going to go get ice cream or something like that. And that is very problematic. We're starting to see that more and more, where people are recording videos of the people who they are caring for and putting them on social media.
That's such a sticky wicket, right? Because I've seen videos that you've stitched where they're fantastic educational pieces. Like I'm thinking about the man that was in the hospital and his wife and loved ones just got up in there and loved on him and stuff. And they were showing his agonal breathing. So clearly he at that moment is not able to make the decision to share it, but the family shared it. And then we don't know if maybe the family said, okay, but especially with dementia, when you're in that in-between place, that's tough.
Yeah. And there are quite a few creators on social media who have a relative who is someone with dementia, and they are documenting that journey. There is one, the Kathy Project. I haven't seen them for quite a while. As a matter of fact, I need to look them up. They're in British Columbia, and Kathy is when they started this out in her early 50s with early onset dementia. And it's well recorded in these videos that have been put out that she agreed to doing these videos. But as she changes, it's a little more, did she really anticipate that the changes were going to be that much? And is she still okay with being, I had a really interesting conversation with a doctor the other day about death with dignity, and how can someone, when they have early dementia, say, I want this, and then later have that upheld. And he pointed out the fact that when you have your early dementia, or your not early dementia, but like it's the onset of it, right? You're like, you've been told you have dementia, and you say, that's it. I want death with dignity, or I want to do VSED. How can you be sure when they get, let's say VSED is a voluntary stop eating and drinking is a better example. How can you be sure when they get to that point where they're no longer able to make their needs known, and you're saying, okay, we're not going to feed her because she didn't want to be fed. She said she wanted to do VSED. How can you be sure that she still feels the same about not eating and drinking as she did when she made that decision?
I have so many thoughts as you're talking. First of all, I feel like you're talking about Canada, because someone couldn't have medical aid in dying or death with dignity with dementia, because by the time they have 6 months or less, they're not decisional.
Right.
But I have had experience with someone choosing VSED with early onset dementia, but they chose it way upstream.
Right.
There are new, this is really in the last, I want to say 5 years, that I've seen directives, which is maybe what you're talking about, directives that people can make for dementia without, like, don't you can offer, but don't feed after a certain point. And I was just thinking, before you started getting to the maid conversation, I was thinking the same thing, like, for agreeing to film someone, it's the same as an advance directive.
Thank you for bringing us back.
How do you know you're going to make that still? Yeah, you just have to.
Can they anticipate that they're shitting themselves and that's going to be part of a public video? How would they know? And thank you for bringing that rabbit hole I took us down. Back to where we were, because that's really what I was getting at, was just because they say in the beginning, yes, I want to do this, how do we know they still feel that way when they're now so demented they can't express what they want or know what's going on, or, and we see that a lot. I guess you just have to trust when you're talking to that person, that they're still, going to be okay with. And in the case of the ladies in British Columbia, I know the sister who was doing the filming of the Kathy Project was really mindful of that, and saying, even though she agreed to this, there is some point where I feel like I might have to say, I can't do this anymore because I need to preserve her dignity. I can't be showing things that are undignified to her, because she maybe didn't anticipate that that's how things were going to go at the end.
For sure.
So yeah. It's still too, it's one thing when it's the family who's doing it, but when it's a hired caregiver, then that's even worse. I
don't even know how that would not be an ethical breach unless you had some kind of. I can't even imagine asking.
It's illegal.
Yeah.
Unless you have something signed from them. So speaking about the guy that I filmed, I took the video off public record, right? So, Hospice Nurse Julie has had people send her videos, and she signs something with them that says, I'm going to use this video for my YouTube for educational purposes, and they agree to it and they sign it. I've never gone to that extent. I take the video that's public. It's out there. It's already on the platform, and I'm stitching it or taking a piece of it.
Right.
I'm using that. In her situation, one of the things that happened was she posted a video of a person who was dying with their permission, written permission. Somebody else took that and stitched it like I do.
Right.
And
it's
she's
public.
like, oh, I told these people that I would be using this for education. And now somebody else has taken this and used it.
Mm-hmm.
So it's kind of like, it made me think, is what I'm doing okay? I mean, it's public, it's out there. And I said that to her. I said, well, it's in the public domain.
Yeah,
So
I think maybe her language would need to change on her contracts if she wants to do that, because once it's out there, anybody could use it.
Yeah. But she was saying that, like, on YouTube, there is some kind of use policy where if the intended use was only for that person, that it's implicit copyright. I don't know.
But you'd have to state that, like, have a disclosure statement at the bottom or something, right?
Yeah, maybe so. I don't know. But it made me question, like, is it okay for me to be doing this? And I have had, actually, somebody has sent me pictures before of their dad, and I used it. And I've never had a family member come back to me and say, why did you use that? Like, they're always thankful that I've actually put it out there. I did have a situation with somebody who was photographing somebody that was terminally ill, put it out on the internet. I put it out on TikTok. I did tag her on TikTok. I believe I tagged her on Instagram, but I didn't even know if she was on Facebook, so I couldn't tag her. And then she came back at me and said, you didn't have permission to post that. I got permission from them to post it. You didn't have. I was like, well, it's in the public domain. It's out there. I tagged you where I could.
Yeah.
I didn't know.
Which is more than a lot of people do.
Right. And it went viral on Facebook, and she was upset because she knew that if something goes viral on Facebook and I'm in the monetization program, I'm getting paid for views for it. And so that's what it really came down to, was she was mad that I was profiting off this video, which in reality, the piece that was hers that was on there was 3 seconds long. It was everything after that I added to it. So, I don't know. But yeah.
Ugh. Social media.
Yeah. Well.
Yeah. Let's get to Cody.
Yeah. Let's get to Cody. Let's do it.
Let's do it. Welcome, Cody. We're so happy to have you.
Hola.
Cody is a palliative care
Bilingual.
chaplain. Are you really?
What's that? No.
Are you really? Oh, dang it. That's one thing I wish I had been studying when I was younger. Was I should have taken Spanish in school so I could have continued that on. So much value in healthcare right now, being bilingual. Oh my gosh.
I know. And I live in Eastern Washington, so I really wish I was, because there's a big Hispanic population over here. And I wish
grew
that
up
I
in
could.
Texas, and I speak Texas Spanish.
Oh.
So all the cuss words and the basics.
Yeah, I know a couple of cuss words. Yeah. I lived in San Diego when I was in probably the 4th through the 7th grade. So I know the cuss words too.
Yeah, there you go. Ordering food and swearing. I can do that.
Well, ordering food is easy.
Yeah.
Enchilada.
Taco.
Por favor. Taco, por favor. Well, we are really already starting off.
We're hitting on all cylinders. Yeah, this is good.
Yeah, we're going down the rabbit hole right off the bat, man. Like, so who cares about death and dying? I'm just gonna talk about speaking Spanish and eating Mexican food.
Really, what's more important than tacos? Nothing.
Nachos.
Yeah.
It's just deconstructed tacos.
True. That's true. All right.
Cody, we have introduced you as a palliative care chaplain and the host of the Dying to Tell You podcast. We're going to have a few more questions about that later. Is there anything else we should know about you as far as your introduction and getting to know you, besides that you used to live in Texas, apparently?
I mean, I used to live in Texas. I grew up there. I lived there for like 22 years, something like that. I've been in Denver, though, for almost 18 years. And Yeah, I've been a inpatient palliative care chaplain at the hospital I work at. The same hospital for 11 years, a
Wow.
little over 11 years. So I did my master's, and then I did some training in a hospital. And my first job outside of training was this job. So I've been there for a long time. I love it. I still love the work. Every now and then I'll get like a little itchy and try to think about what else I can do. But, I take a little break and then I come back and I just I don't know. I love being in the hospital. I love the palliative care work. It's really good stuff.
Cody, where in Texas are you from?
I grew up in the Dallas area, but I've lived, I went to school in West Texas in Abilene, undergrad. And then I lived in a small town called Hillsboro, Texas for like a year and a half after I graduated from college.
I'm asking because I'm half Texan. My dad was from Del Rio, Texas.
Oh, really?
Mm-hmm.
With Radney Foster. He's from Del Rio. He's a country music singer.
Oh, yeah. It's interesting to me. I'm going to go down the non-hospice palliative rabbit trail again here, but how the accents can really vary from one area of Texas to another.
Mm-hmm.
Like, to me, you don't have a real strong Southern accent. And my dad's wore off over the years too, but my relatives who stayed in Texas, I couldn't hardly understand them. Like, I couldn't talk to my grandmother on the phone because she had such a deep drawl that I couldn't. I was just like, I can't even understand what she's saying.
Yeah. Mine comes out from time to time. Like, if I'm talking to somebody that my parents still have a pretty strong accent. So if I'm talking to them, it comes out. My wife calls it a schwa, not a drawl. It's a Texas schwa, but she says that Texas is not really the South. That the people from the South, like Georgia, Tennessee, they have a drawl, but Texas has a schwa. I don't really know what that means, but it comes out from time to time, and depending on the words I'm saying and how many drinks I've had, I guess.
Yeah, I was going to say, no, I actually, I never lived in Texas, but I definitely have a Texas accent if I've been drinking. I don't drink anymore, but when I did, I was like, I used it to get myself out of trouble with cops.
It's kind of a lazy way to speak, so it's easy to do when you
is, right? Like, it can hide a slur, like it can hide, that drunken slur if you speak with a Southern accent. Okay.
Cody, this is what she does to me. She makes sure I keep us on track.
I will stop going down all the rabbit holes. All right.
I'm going to come back to Denver. You said that you had been there for 11 years. That means you went through the COVID times in the hospital.
Yeah.
So tell us about that. How was that? And also in that question, I wonder, do you cross over into the hospice in the hospital world, or are you just strictly palliative care? How does that look?
Yeah. So which one to answer first? Yes, So I'll talk a little bit about COVID. So I'm like a non-alarmist when it comes to stuff. So in 2019, we're getting wind of some kind of big virus thing happening. And in the beginning of 2020, I'm part of the ethics committee, and one of the other ethics committee members brought this article about everything that was happening in Italy and how we need to be ready for, rationing ventilators and stuff. And I was like, nah, this is not going to happen. It's not going to be a big thing. It's, people are blowing this out of proportion. And it turns out that I was wrong about that. COVID was a big thing. And it's just, I don't know, it just happened all so fast. And they closed down everything, and they were like, well, all non-essential people stay home. And I wouldn't have thought that I was essential, honestly. But turns out I worked through the whole pandemic, so we just stayed there. And as a palliative care team, we followed all COVID patients in the ICU, which really meant we were working with families of COVID patients. And so, we spent, I don't know, like 2 years just almost completely working in the ICU, just helping people. It was just like a waiting game. I guess you guys probably know that, but at one point the mortality rate in our ICU was like 80%. Oof. Because when somebody gets that sick with COVID, it was just that was it. I mean, we obviously had a lot who made it through. We had we're at ECMO center, so we had people on ECMO. These young folks who
what's ECMO?
It's a heart-lung bypass machine. So they use it to oxygenate somebody's blood when their lungs aren't able to do that anymore. So we had these young people, 40-year-olds who had no previous known medical conditions, who would get so sick, and then they would just come here, and we would just have to breathe for them and pump their heart for them until it became clear that it wasn't going to happen, that they were going to die anyway, or they would just make it through, and it would just take months and months. And then they would get out of our hospital and go to an LTAC or a rehab facility, a SNF. And they would, eventually we had a few that would walk back into the hospital and come and say thank you for everything that we did. But it was wild. I mean, there's just a lot of Zooming people and just people watching their loved ones die over Zoom, which is just surreal. It's just I don't know how to describe it other than that. It was just, and it became normal to us. So it was honestly at some point it was just like, well, this is how life is now, and we just always wear a mask, and we always Zoom people into everything. But now thankfully we're back to mostly normal. But
can I ask you?
It was hard.
What does that do to you spiritually? Like, how does that impact your religious point of view? You're a chaplain. We know there are atheist chaplains, but all the chaplains I've met are pretty much religious and practice in one religion or another. And, how did that impact you in that way?
Well, I'm not, no, I'm not religious. I'm a humanist. I'm a humanist chaplain. So I'm endorsed by the Humanist Association. And so, I don't hold to any dogma or anything. And it's, but, spiritually, I guess spiritually, emotionally, as a person, I don't know. I think that while I was doing it, I didn't really, it's what's happening. It's just what we're doing in the moment. It just kind of, like I said, became normal. It happened real fast. Everything shut down, and all of a sudden we're all wearing masks all the time. And we didn't really have a lot of time to sit around and think about what we were doing. We were just doing it. But it certainly, and I guess working in palliative care or in hospice, I'm constantly aware of, just death, mortality, the fact that I am going to die someday. And, but I do think that one of the things, kind of a theme for me during that time was just a recognition that we're not as safe as we all think we are. We do all these things, we create routine, and we create these kind of rules for life about how we do things. And it makes us feel like, I'm definitely going to wake up in the morning. I'm going to be okay. And for the most part, we are, right? We do wake up but the reality is we're not guaranteed that. People people die all the time unexpectedly. And this was just like a real, kind of a kick in the gut. Like, oh, you could get this virus. I could have gotten that virus, and I did get the virus eventually, like, I think 2021 at some point, and I felt like shit, but I didn't go to the hospital. But the reality, it just made me very aware that I'm not quite as safe, not quite as invincible as I thought I was. So it's not, that's not distressing to me. It's just a realization, and it's kind of helped me be a little more mindful about enjoying what I'm doing and just appreciate life, which is, it's the whole point of my podcast. It's the point really of my working in palliative care. Is not, I care about my patients, but it's a learning for me. This is a gift for me. It helps me be a better person and live with myself in a better way. So, I think it was difficult for sure. I don't know. I didn't find it as distressing as a lot of people did. And I don't blame them for that. I think it was definitely distressing. And I think nurses, especially nurses in the ICU, had it way worse than me. They're just constantly, it was just, we were proning people,
putting them on
like
there,
flip-flopping people. And that's all, we're just prolonging life with ventilators and ECMO machines. And sometimes it worked and sometimes it didn't. And there wasn't really, we didn't have that much control over whether it worked or whether it didn't, because people's lungs are just trashed, and we were just waiting, and they are just doing all this care, intense amounts of care for people that they're not really sure. I guess that's always the case, but there's just a lot of people and a really bad situation.
Well, I think for the most part, ICU nurses are used to probably most of their patients surviving. They do get experience, with an exposure to some death in the ICU, but it's definitely more about it's critical care. It's like doing everything that you can to keep a person alive, and probably the majority of the time they do,
right?
But not during COVID. I'm saying that as somebody who just watched a lot of ICU nurses on social media, and how that impacted them, because and many of them were new grads, and we don't learn about death and dying as much in nursing school, just like in medical school, like that's not the focus. The focus is on preventative and treatment. It's not about death and dying. You go through nursing school, you might get an hour lecture on hospice and palliative care, but for the most part, you don't get that experience. You certainly don't get it in nursing school as far as your clinicals, so it was like, oh, wow, I did not know that this was going to happen, and I think that's what was really, really hard for them. And I was watching LPN social media content creator, and she was in the thick of it big time and talked a lot about it during that time. And then she just recently put a video out talking about it again and saying how she was holding the Zoom for people to see their person dying, and she just never expected that was going to happen.
Yeah, I think that's right. A lot of people were exposed to dying that normally aren't. We're really good at keeping people alive. We really, not me, but the hospital in general is really good at keeping people alive. And
far beyond when they should be, let's just say.
Perhaps,
yeah.
Halley, you asked about palliative care versus hospice in the hospital, and I do palliative care. So we really are just palliative care. However, a lot of times when people have done everything possible and it's not working anymore or whatever, and they are in the hospital and ready to transition to comfort care, if we don't think that they're going to be able to get out of the hospital, we will do that transition in the hospital, and we will provide that care for them. And so the palliative care team will be part of that. Our doctors are not attending or are not admitting doctors, and so they don't. The primary team remains their primary team, but we consult, and so the social workers and the chaplains will provide support to patients' families. We don't do GIP in the hospital very often, just because it's kind of it's a hospital culture thing for us. We haven't historically done that, and so we're not good at it, and so it just doesn't happen very often. We're trying to get better at it, and we need our hospice partners to be there and available and able to do that, but we don't typically do that.
And for those who don't know,
just
who are
listening,
GIP is a hospice level of care, general inpatient care. It's really meant for acute symptom management. And one of the problems with doing GIP in a hospital setting is that it's hard to justify that they're meeting that eligibility if they're just comfortably actively dying, because that is not a qualification for general inpatient care. They really need to be having some aggressive symptom management going on, ongoing assessment. So it is actually a really slippery slope to have somebody GIP in a hospital.
It's hard to do, and I think that's part of the reason why we haven't historically done it, because it is hard to qualify somebody, and honestly, it's more comfortable and just gooder overall to do it outside of the hospital. If somebody can get out of the hospital, it's more comfortable. It's more family can be around, and it's just, hospital's a sterile environment. It's not great.
Mm-hmm. Yeah.
Well, I'm going to redirect us just a little bit, Cody, because I think you have quite a social work heart when it comes to your passion of advanced directives and planning. So where did that passion come from?
It's just part of what we do as a team in the hospital. So on our team, and probably I'm imagining at other hospitals too. I don't know. I haven't worked at any other hospitals. So the work that we do as a team, there's a lot of overlap between social work and palliative care, or social work and chaplaincy. And so historically on our team, the chaplains have addressed all advanced directives, but medical power of attorney, we really, over the years, we have tried to meet people further and further upstream. So as soon as they have some kind of a life-limiting diagnosis, we're trying to go, right? I know. But as soon as we can, we want to get them, and we want to talk to them. Okay, you don't need a medical power of attorney right now, right? But you don't need a medical power of attorney until you need it, and then it's too late. And so you've got to do it. And so we're trying to do this as early as possible. And so historically, on our team anyway, the chaplains have been doing that. We've gotten trained through that group out of La Crosse, Wisconsin. Respecting Choices, I think is what it's called. But we've gotten training through them and through Kaiser to do conversations for MOST, or you guys probably have Pulsed or Post, or I don't know what you have.
But, Pulsed in Washington.
So we've gotten training to do that, and so we will work with. That's another thing, is that we're trying to we're a teaching hospital, so we're trying to educate the resident doctors who are there. So I'll grab a resident and we'll go have a conversation about a MOST form with a patient and talk them through, this is what this means, and this is what that means, and this is how you should be, we want you to be thinking about the decisions you're making. And so in doing that, we're getting the medical information that we need from the resident doctor, but he or she is learning from us about how to have that conversation, and then the patient is learning about medical decision making and thinking with us about how they want their care to look. So to answer the question, really, which was how did I get kind of an interest in that, it was really given to me because it's my job, but I also think it's really important. And
that's fair.
Yeah, but I think it's really important, and it's something that a lot of people don't do, and I think they should.
When you talk a lot too about longevity of healthcare workers, which is also vital and vitally under discussed. So what are things that you're doing to advance that?
So we work, again, a lot with young residents, and we have a lot of new grad nurses that come to our hospital. We have a nursing residency. So for the first year of their work in the hospital, they have this residency program where they have these educational days. They come in and do all this education stuff. And so some of what I've been trying to do is talk about how to maintain your own well-being, through self-care, and it's not self-care in the sense that, I'm drawing a bath and, drinking a glass of wine and eating chocolate, which is fine. I like a bath as much as the next guy, but, the ability to encounter these kinds of difficult things over and over again and maintain yourself. So I think it's the kind of people that go into healthcare are caring people. They want to be caring, they want to connect with people, and all of that is good and fine. And if I am taking on the emotion, taking on either counter projection or projecting my own beliefs onto them, getting my own stuff kind of mixed up in their stuff, it can be devastating. So the things that I talk about are being aware of yourself. Like, what is it that triggers you? What is it that hooks you in and makes you want to do more than you need to be doing? What is it that makes you really, really hate a patient or really hate a family? I mean, we all have these kind of biases and triggers and things that kind of hook us in. And if we walk around and kind of do our work unaware of it, it will ruin us, and it won't serve the patient or the family. And so I think what I talk about is allowing myself to have my experience and to deal with that experience, my own internal experience, deal with it internally, and let the patient and the family have their experience and help them through that experience, but not getting those two mixed up, because what I feel about what they're going through, it's none of their business. They don't need to know what I feel. They need me to be there and be professional and help them work through their stuff. So it's, remaining curious about what's happening. It's being aware of my own biases and my hooks and my the things that I really hate. That's a big one. So that's what we do. We just try to we have a every rotation out of the ICU, the residents toward the end of the rotation will do we call it resiliency rounds or something like that, where we just take a morning and kind of talk through that whole month. Okay, what was hard about this? What happened emotionally? We're not talking about medical stuff. We're talking about emotionally, what was difficult for you? Why was it difficult? Let's pay attention to that. What was great about this? Let's pay attention to that. And so just kind of working through all that kind of stuff. So we do the same kind of thing with nursing staff and anybody that will listen to me. That's what I say.
Yeah. Whenever I'm talking to other clinicians, especially nurses, about how to survive, because I get that question a lot. How do you do what you do?
Yeah.
I always talk about emotional boundaries. You've got to have not just professional boundaries, but emotional boundaries.
Yeah.
That's not your family. This is your job. You can't get enmeshed in what's going on with them. You can't try to fix what's going on with them. Whatever's happening in that dynamic has been there for long before you walked into the picture.
Right.
And for me, one of the more concrete things that I could do that helped me with that emotional boundary is to not attend funerals. Because I did not have the bandwidth. As I started in GIP care in hospice care centers, 2 different hospice care centers for 7 years, where literally, 5-6 patients will die in a weekend.
Yeah.
I wouldn't be doing anything but going to funerals if I went to, So it's kind of like I needed to say, if I'm not going to do this for this person, then I can't do it for anybody. Like that has to be my hard line right there. This is my emotional boundary. I cannot be putting myself into, this funeral or memorial service in my own private time, day after day, and survive this work.
Yeah. 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 The thing about, like all the stuff that's going on in that family has been going on for years and years. Made me think of this patient we had in the ICU a couple of weeks ago, and this family was they were just fighting. One family member was like, he's suffering, we need to let him go. Another family member was like, he would want to live even if it's in a facility. And of course, like I have my bias, right? And I know what I would pick. And so I had to be really careful about not giving preference to this man who I agreed with, right? Because the lady who I disagreed with, they're both having loving responses, right, to the person in the bed, and their inability to talk and work through that on their own it's something that I can work with, but it's not something I can change because it's been happening for 50 years. These people have lived as family for a long time, and they've developed this way of not communicating well. And that's how it is. And I can interject and I can work within it, but I can't change in 2 days what's taken 50 years to develop. So, so not only am I kind of just trying to separate myself, my own bias out of that situation, I'm giving myself a little grace for not being able to fix the situation, because what am I going to do? This lady loves her father deeply and is terrified that he's going to die. This other man loves his father deeply and is terrified that he's suffering. And what's the reality and what's real? What's true about that? Both. They're both true, and they're both loving responses to a difficult situation. So, it's hard to do. It is hard to do. And I was not always good at it, and I'm not always great at it now, but, that's the idea anyway, is to, set those emotional boundaries and professional boundaries.
And another great example of why we need to have those conversations upstream, and that we talk to our loved ones about what we want.
Wouldn't it?
Yes.
Yeah. And what a great story. And I'm sure Halley will agree with me that it's one that we've heard play out over and over and over again. Different characters, same story.
Yep.
Yeah.
Yep.
For sure.
It really hammers in the need to make your wishes known.
Yeah. So anybody that's listening to this, now's the time. Talk to your family. Yeah.
Yeah. You don't have to wait for a life-limiting illness to have this conversation. In fact, you really shouldn't, because aliens could come out of the sky.
It's too late.
You could get in a car accident. Who knows,
Yeah.
So Cody, tell us a little bit about Dying to Tell You and where that came from, because I'm dying for you to tell me where you find your guests.
Well, I'm just dying
where I find my guests? That's always the problem, isn't it?
Oh my gosh. I've had this conversation so many times. I know I've told Penny that I've talked to, 1,000 people with amazing 1,000 different stories, and they're my hospice patients, so I can't ask them to be my guests. So and I have a really hard time making up stories. I'm not good at changing details enough for me to feel comfortable telling stories. So you don't often hear me telling stories for exactly that reason, because I'm so worried about telling stories. But you're finding people that are willing to tell their own stories. So Tell us all about
which
that.
is so much easier. Yeah. So the idea just came because I was sitting out with my family and friends, and I was telling a story about somebody that I met, that was dealing with illness, and how great it was. I mean, I just learned so much, obviously, from doing this work. And they were like, "Man, it's so great, these conversations that you have. You should write a book, or whatever." And I said, that one, that's really hard, and two, like changing the names, and like, what is the legality with all of that? And my wife's a lawyer, and I'm always thinking about that kind of stuff. And so but I was like, these people, they're not dead, they can tell their own story. It would be cool to interview these people and kind of give people a little peek behind the curtain of like what I do, and kind of these conversations that I get to have with people. And so I kind of floated that idea, and my wife goes, "Who the hell would listen to that? It's so depressing." And I was like, "Oh, well, maybe, but I don't think it has to be. I don't." And so, it was just this, because I don't find it depressing. It's life-giving and meaningful. And so I was just like, maybe we can do this. It takes the right person, right? Somebody that's, has a life-limiting illness, something they're going to die from, somebody who is aware of that and accepting of that and willing to talk about it, and somebody who's not so sick that they can't talk about it anymore. And somebody willing to let strangers in on the conversation. It is kind of a tall order, but I felt really strongly that this would be a good thing to do. And so I found my friend Chris, who does my kind of producing and editing, and we talked about it, and then I just started putting the word out to my palliative care friends outside of the hospital who would have patients that I'm not going to see.
Right.
And just started saying, "Hey, if you know of somebody that would be willing to talk, let's talk." And my friend Andy is a palliative care physician, and he works within the same palliative care group, but at a different clinic in a different hospital. And he said, "Hey, I've got this guy, and his name's Aaron. He was our first guest." And he was like, "He's exactly what you want. He's got, an end of life plan. He's got all this, like these, he's got rituals and stuff that he wants to do. And he was like, he really is dying to tell people about this. He really he wants people to know. And he's got a message about, like, you need to start planning for end of life, because, death and taxes are the only sure thing. And everybody plans for their taxes every year, and nobody's talking about death. So now's the time to talk about death." So we contacted Aaron, and we set up a time to interview him. And then the pandemic happened. And so we were like, well, we're just going to put everything on hold for now. And eventually he contacted us and said, "Look, I've got new meds in the brain, and if we're ever going to do this, now's the time. So let's get together and do it." And man, it was so good. And I think we probably have 2.5 or 3 hours worth of interview with him, because he just had so much to say, and he was on high dose steroids, so he was just like, but anyway, he was great. And that kind of started it. And you're right, finding the right people has been the biggest problem for us. And so we just kept putting the word out, and we finally got a couple recorded. And then we were like, it's not a good idea, but we're going to start the podcast. We only have a couple in the bank, but we're just going to start it and hope that people will come to us through this podcast, and starting to like put stuff out on social media and stuff. And that's really where we've gotten a lot of stuff. A lot of our guests is through social media and through people that I know who work in the medical field who have patients that I'm never going to see. So, yeah, it's just so much fun. Honestly, it's so, I don't know. It's life-giving and meaningful in a way, a different way than the work that I do in the hospital. And, yeah, I just love it. I love it.
Yeah, I imagine you've learned a lot from all those people you've talked to. And I was just listening to your most recent one where someone has a plan for medical aid in dying, which of course Colorado is one of our sister states that has that option for people.
Yep.
And it was a window into his lines in the sand, which I thought was a great part of the conversation.
Yeah. Bob is so great. I would like to, at some point, hopefully in the next few months, get back together with Bob and his daughter, because Bob's wife, and I don't know if it actually made it into the final cut, but Bob's wife had dementia, and she voluntarily stopped eating and drinking. And that's how she came to the end of her life. And to hear him talk about that and was just, it was heartbreaking in some ways, and also just, man, he was steadfast. I mean, just he prolonged his own life with chemotherapy that he would never have done if his wife hadn't needed him to be around for that. And that was wonderful to hear about. And yeah, I've learned a ton from, I've changed the way that I practice through these interviews. It's been really great. Really great.
Anything surprising that you've heard in your work or in your interviews that caught you off guard?
Yeah, the one that I think has really shifted for me is I really shy away from, or I've always had this kind of, I don't know what to say. I've had kind of a bad reaction when people use the fighting words, or military words. I feel this really terrible feeling in my stomach when somebody has gotten this new diagnosis that is metastatic cancer, that we know they're going to die with it, and they say to me, well, I'm going to beat this thing. And I've always had this kind of immediate reaction to that, well, I need them to know that that's not true. Like, I need them to know that they're not going to beat this. And Nancy Kay was, I think, the second guest on the podcast, and she used that term. And I guess because of this different setting that I was in, and I had a little more freedom to explore, I just said, we know that you're dying from this. What do you mean? And she's like, well, I'm going to beat this by living as well as I possibly can with this, right? Like, I am going to beat this by doing everything that I want to do. I'm not going to let it beat me. I'm going to beat it. And so I still don't like the terminology. I don't like those words necessarily, but it's changed the way that I react when I hear that. And I, instead of having this kind of shut down posture and need to like fix it, I find myself coming in a little more curious and a little more open to that, and saying, okay, well, let's talk about that. What do you mean by that? And how can you beat it? If it's going to kill you, how do you beat it? And, so that's been kind of my big learning so far, is not just that, but any kind of turn of phrase that makes me feel bad or have that kind of like shut down reaction. I can just notice that and go, okay, I'm having that reaction that I normally have. Can I get with it and stop and just give it some time and let that breathe and just like explore it, be a little more curious about it and not so judgmental about it, which is my typical response. Is just being a judgmental asshole about stuff. So,
well, I really like that. I really love that you explored that with her and that was her answer. I really like that because I'm triggered by that as well. I'm especially triggered when people say they lost their battle with cancer.
No, it's so like, hard.
It's like, you don't have a loaded weapon. You know, you can try all you want, but death is going to take you when it's going to take you. And sometimes there's nothing you can do about that. It really triggers me. And then I'll hear people with cancer saying, I'm going to fight. And I still feel triggered. And my outward response is, well, you're the one who's going. And I've even made videos where I say, look, if you got cancer and you want to say that you're going to fight it, okay, I'm okay with that. But let's not say that somebody lost their battle with cancer after they've died.
Yeah, well,
it's really not fair to them to say that.
Right.
Exactly.
Yeah.
But still, even though I'm kind of giving that permission, like if you have cancer and you want to say you want to fight it, I feel the same way that you just described. Like in my brain, I'm thinking, what the fuck do you mean by that?
Yeah.
You know, like you're going to die from this. You have stage 4 metastatic cancer. It's in your fucking lymph nodes, dude. Yeah. Like that's the freeway to everything in your body. You're going to die from this. What, you know, but you know, I give them the grace, but so I think it's really cool that you were able to explore that and that her definition of beating it wasn't, I'm going to eradicate cancer and live until I'm 90 years old.
Right.
It's, I'm not going to let it get me down. I'm going to do what I can to live as long as I can. I'm going to have a good life. I'm going to, you know, like, I really like that. Not to say that's probably everybody's idea when they have cancer. Some people who are trying to, you know, beat it are really trying to beat it and to live as long, you know, forever and get rid of it completely out of their body. But it does, you know, give me kind of a little new perspective to try to squash the voice in my brain that wants to go.
Yeah. Like I need to shake him and go, you're gonna die from this. I mean, what good is that? I mean, that's not gonna help.
I mean, but to be fair too, part of that is, let's look at what else could, you know, like you need to do your advanced directives. Like if this doesn't work, then you should be taking this pathway, right? Like Dr. Sammy's book, Hope for the Best, Plan for the Rest.
For the worst. Yeah.
Yeah. So like just, you know, like let's walk 2 pathways here. There's the one that you're going to stay focused on, but on the side road over here, we've got this.
Yeah.
So that you aren't coming onto hospice 3 days before your death, and we're scrambling to make everything work out for you to be at home with your family and to teach them and to do all this stuff. It's like trying to, the balance, you know, walking that thin line in between.
Yeah.
So I guess probably that's why I get that triggered feeling of stop saying that you're going to beat this.
Yeah.
You know?
Yeah. Yeah. Well, I mean, I'm seeing people when they first get the diagnosis. And so it is, you know, give them a minute to let it run around in their head a little bit.
Yeah.
Like, can I just chill out a little bit and let them sit with it for a minute before I shake them and tell them they're going to die? Like, they'll figure it out. And, you know, we can help them through that. And, you know, I always say, you know, like people will say that, there's always hope. And I ruffle my feathers at that too. Like, yeah, there's hope, but you know, what are you hoping for? Like,
well, we'll be talking to Dr. Sammy this season about specifically that, because she has an amazing chapter in her book and part of her podcast that talks about reframing and redefining hope as we go down our path. So we'll put a pin in that thought for now.
Because there is always hope. And what we hope for changes as our situation changes.
Hope for, That's what I say.
The same thing.
We don't ask you to give up hope when you come on hospice. We ask you to change what hope means to you.
Right. And people will say, well, I'm not giving up. And I'm like, yeah, nobody gives up. I've never had a patient that gives up. That may not be true. But generally speaking, people don't give up. And, you know, you want to fight? Great. What are you fighting for? I don't need to change your wording, but I need to explore that with you. And if you're just using that as a deflection so that you don't have to like emotionally deal with it, well, I can figure that out too. But we can also get past that, and you can like work through it, and you can figure out, okay, because I think that a lot of times is just a fear response, right? I'm going to fight, you know, and okay, cool. And most of the time, making decisions out of, you know, a reactionary fear is not the best place to be making decisions from. You know, if we can give a minute, let that fear breathe, work through it, and then go, okay, but logically speaking, let's take some time to think about what's most important here, and how are we going to get you the most of what you're hoping for, and help you avoid the things you want to avoid, and help you live as well as you possibly can now, right? You're not dead. And so like, how do you want to live?
Yeah.
And isn't it a beautiful transformation when they get through that minute and they start to like really reframe how they're thinking about the end of their life? You know, it's beautiful to watch that unfold. I saw that happen on TikTok with a young woman. I've probably talked about her last season, Jessica Christine. She had, I don't know if you were on TikTok at the time, Cody, that she was on, but she had colon cancer. Young woman, found out that she was dying. They were putting her on hospice. She was terrified, made a video, 10 million views. People in the comments, Hospice Nurse Penny, help her, help her, help her. And I was just like, let her sit with this. Like, let her feel her feels. She needs to.
Yeah.
And then once she worked through that and started like accepting that she needed to change her plans, it was beautiful. Yeah. She had a bucket list and people helped her. And this guy did a GoFundMe and people raised money for him to go make her beignets. That was on her bucket list, you know, and it was, you could see this unfolding in real time on TikTok. And it was just beautiful to watch, you know, like her just finally, and it's not even about embracing the fact that she's dying. It's accepting the fact that she's dying and embracing what life she has left and trying to live it the best way that she can. And it was just amazing, you know?
Yeah. And I mean, part of why I love all this is that I think I'm about to say it in one of my podcasts, is my situation really is not that much different from somebody else's situation. Our next guest has ALS, and she's, you know, her timeline is truncated, right? It's compressed, but she's losing her ability to do things that she's always done. So am I, right? Like, I'm not running a marathon anymore. My knees won't do that. She's not running a marathon anymore either. It's going to take me a longer time to get where she is, but I'm going to get there. And so, can we just take a moment and realize, like, there's nothing wrong here. And we all have this condition, and it's happening, right? And now is the time to be living the way that we want to live. And that's another thing that is really, like, through doing this podcast and working in palliative care, is just, now's the time, because I am not guaranteed. Like I was saying about COVID, I'm not guaranteed to wake up tomorrow, and I better enjoy today.
Well, that's a great transition towards the end here, because I want to honor your time. I do want to we don't have to get into it, but I just wanted to make sure I mentioned that I love your gratitude and remembrance posts on social media. So if people are not following you on social media, they need to be.
Yeah, do that. Yes, please. That's one of my favorite things, is having people talk about people that they've lost and that they love, because, you know, we all carry things with us that were given to us by family and people that we've loved, that we've lost. And that's one of the things at bedside when we're, you know, extubating somebody and they're going to die. We always talk about, okay, you know, what are you taking with you from them? You know, how are you going to honor them, and how are you going to live in a way that honors who they are, and what have they taught you? And so, in fact, when we get off of this, I'm going to make another post, and we're going to invite people to share, just a remembrance of somebody that they love. So if you're not following, please follow.
And I will ask you in a second where to find you. You're muted, Penny, by the way. But we're starting a new thing this
My
season.
stomach was growling, and so I muted myself.
Mine was too earlier. I hope it didn't make it.
Can you hear me? I'm gonna move my microphone away.
No, I couldn't hear you. This season, we're asking a question to everyone. So you're going to be our trial question here.
Oh, okay.
The coffin question is, what do you want done with your body when you die?
Oh, I really don't care. That's the real answer. And also, I don't like the idea of pumping my body full of preservative and putting me in a box to be preserved, even though I know that eventually I'm going to rot. So I don't like that. Cremation's
got a lot of
cool.
new options lately.
Yeah, I know. Creation's cool. We had a couple people recently do the composting. What was it? I think there was like a water composting thing that they were doing.
Aquamation.
Aquamation.
Mm-hmm.
Yeah. Any of those, I suppose. Honestly, if you just like wrap me up in a blanket and toss me in the ground, that would be fine too. I just don't like the idea of being like all preserved. That doesn't sit right with me. But I don't think that I'm gonna care. I'm open to something after life, but I'm not convinced, and so I don't think that I'm going to care what anybody does with my body. So, but if anybody's listening out there, yeah, don't bury me. You can cremate me or compost me or toss me in a hole.
No, I was going to say, make sure you tell your loved ones about that.
Yeah. I think they know.
Well, where can people find you? We've mentioned it a few times, but I just want to make sure we're clear about where people find you, and we'll also put it in the show notes.
Okay. Well, let me look. I don't know the name of my the dying.to.tell.u on TikTok, and then Dying to Tell You on Instagram, Facebook. But DTTY Podcast is the website, dtypodcast.com. And we're on, all the places, Apple Podcasts, Spotify.
Wonderful.
But subscribe. It helps if you subscribe. And then it automatically downloads, and then we get all the warm, fuzzy feelings when we see all the numbers.
Well, Cody, thank you so much for being a guest today. We've really enjoyed talking to you.
Yeah, thank you. Yes,
it's good
fascinating.
Good to meet you guys in person.
You as well.
Virtually in person.
Wow. How inspirational to remember, as we say, someday we'll all be dead. It's true. Life is a terminal condition.
Yes. That was fantastic. I really enjoyed talking with him. I haven't listened to his podcasts. I've heard pieces of them on social media. Now I'm going to be subscribing and binging to everything because how fascinating. And I love that, we know that people who are dying do want to talk about it, and families are often reticent to have those conversations. They're uncomfortable. Nobody wants to broach the subject because everybody's afraid that nobody really wants to talk about it. So nobody brings it up. But, there's been studies that have been done where they have shown that people who are dying do want to talk about it. So I love that he's giving them, the platform to do that. It was a great.
I mean, I'm sure you've had the same problem. I can't tell you how many times I've had family members say, "Don't say hospice." Oh. Even to decisional patients, don't say hospice. Like, what are you doing?
Just for everybody listening, we can't do that. Electing hospice is, you're electing the hospice benefit. It requires informed consent. So somebody who's decisional or somebody who's not decisional, and then the family elects it for them and says, don't tell them hospice, but then maybe they've had a stroke and they start to kind of come around or have some clarity. We now, we do have to tell them that they're on hospice. We are obligated. So, and unless it's somebody who's, really doesn't have the cognitive ability to understand what that means, or it upsets them every time you talk about it, then of course. But, if they're decisional.
Yeah. I do have or have had a patient that had a kind of a trauma response every time because the short-term memory was so bad that it would re-trigger that, like you're getting the diagnosis all over again. And that I understand, completely get it. We're part of your care team. That's all that's important to say. But yeah, it's exhausting when you're trying to do this education and be supportive, and you can't even offer what you really want to offer, which is the allowance for them to grieve.
Yes, grieve their life, grieve the end of their own life. Yeah, absolutely.
So yeah, Cody's doing good work out there.
Yeah, he is.
All right, well, until our next video, until our next interview, remember to live.
Because someday we'll all be dead.